Good evening, everyone. It's indeed a great pleasure to welcome you all for the second episode of our PG classes webinar series, AKSHARAM. This is the episode 2 after a very great success with our first episode, and many of the PGs and other people have actually called us and asked, Madam, when is the next class? And we're very happy to have the second episode this time. It's about ovarian cancer, basics to advance. We all know that ovarian cancer is a very elusive cancer and it presents very late. Many people come actually with the GI symptoms. So here we have with the second episode with the most coveted teacher, Dr. Ramak, who is going to talk about ovarian cancer, recent advances, screening, tumor markers, and familial oncogenes, everything. Now I'll start the presentation. Is my full screen visible?
Yes, ma'am.
Yeah. So this is a combined effort by the Oxy Medical Education Committee and Foxy Medical Education Committee. We had Dr. Kiran Pandey, who is the chairperson of Medical Education Committee of Foxy, and Dr. Vijaya, President Oxy, and also the chairperson of Medical Education Committee of Oxy, combined program. And here we go with the second episode. And I also thank the office bearers of Foxy and Oxy for this wonderful program. Now, I call upon Dr. Vijaya to give the welcome address. Vijaya Madam is the professor and HOD of ESI Medical College, KK Nagar, Chennai. She's a former director of IOG, Madras Medical College, Chennai. And Madam has lot of credits and awards. And she has special interest in high-risk pregnancy, infertility. And she's a very dynamic and very meticulous president of Oxy. And we are very happy to work with her. Over to you, ma'am.
Hi, Karpagam. Thanks for the lovely words. Extremely happy to welcome Kiran ma'am. I'm so happy she is able to make it today. And I'm very, very thankful to Rema because the moment I called her, she accepted. Every month, I am just breaking my mind because for the PGs, it should be from an expert teacher and she should be able to clear all your doubts. So all the speakers or the teachers are handpicked by me. So every month, so this month is over, next month I'll start thinking from tomorrow onwards what should be the next class for you. It is all exam oriented and whichever clinical topics only we are going to cover. We are not going into the theory classes. So all the PGs you and although the young consultants, you just log in and then enjoy the session. And also from the next month, at least you tell your friends and colleagues to join in for a lovely webinar program, which is entirely given to you free and you sit and enjoy. Thank you.
Thank you, Vijaya ma'am. Now we'll go to the next. Lighting the lamp. We always start all our programs with this lighting the kuttu velakku.
Sakiti, no music. Sahiti?
Yes, ma'am.
No music.
Music is not there.
Now with a small shloka.
I will share, ma'am. Music is not audible, ma'am.
Okay, what about this?
Now, I welcome Dr. Geeta Lakshmi. She is our Secretary of OXI. She Associate Professor of Chengalpet Medical College, undergraduate and postgraduate teacher for past many years, and member of Chennai Menopausal Society and ISOPAR. Madam will be entering the OXI prayer.
Thank you, Dr. Karpagam. It gives me an immense pleasure as the Secretary of OXI to welcome one and all for this second episode of AKSHARAM, which has been widely accepted and appreciated by all the students, postgraduate students, and they are eager to do that. And I appreciate our president for taking so much of interest in the clinical topics and to find the best teacher. And today also we have the best teacher with us, Professor Dr. Rama. And all things should be started with the blessings of the Almighty. So I go on with the OXI prayer. Thank you, God. In humility, we gather. In gratitude, we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and mom reborn, the courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. So we'll go on to the program, Karpagam.
Thank you very much, madam. Now, I would like to introduce, I would like Vijaya madam to introduce our chief guest, Dr. Kiran Pandey, who is chairperson of Medical Education Committee. Over to you, Vijaya ma'am.
Yeah, Kiran Pandey ma'am is such a lovely and friendly person, and she's a chairperson for the Medical Education Committee in Foxy, and for almost all the OXI medical education programs, she will be with us. Even today, she had a conference in Lucknow, and she said she might not be able to log in, but somehow, for God's grace, it got over early. And ma'am, thank you so much for joining in, ma'am. And she has lots and lots of, but she's a very active member of Foxy, and she's has lots of research, and also she's a very good teacher, per se, and she has got even in IVF and laparoscopy and ART procedures, she has got several degrees and diplomas. Madam, thank you so much, madam. Just welcome to you, and over to you, Kiran ma'am.
Thank you. Am I audible?
Yes, ma'am.
Yes,
Okay. Thank you, Dr. Vijaya, for lovely words and kind the appreciating words you said about me. And it was really a God's grace that I could join. I was worried. And in fact, I tried to talk to you also that how we will manage, but something or other kept on happening and could not. But that was the wonderful, and that's the beauty of the thing that I'm here with you all in this second episode of Aksharam. We discussed, and in the very beginning, and I liked the best thing about you. You were so passionate about finding and exploring the best persons of the country to talk on those different aspects. This shows your passion, how much you are concerned for the postgraduates, and I'm sure the postgraduates who are attending them will be very much benefited by the today's webinar and the coming webinars. Today is a very important ovarian malignancy, which is a silent killer, it is called, because there are no specific symptoms. And many a times when the patient comes and you see, then it's an advanced stage and they don't know anything. And it's really difficult to counsel them and explain them. And you becomes in a dilemma how to explain, how to, and what to do now, because there are not much options, although the advancements are happening and newer drugs are coming, and we are trying to save the patient, but still mortality and the prognosis of the advanced cancer is very limited, and even with the good drugs, 1.5 to 2 years are the basic things, unless and until very accidentally diagnosed in the very early stage. So this is friends, younger friends, I would say it's a very important thing for our topic, and you should be very careful and properly concentrate on this on each and every aspect. And Dr. Vijaya is trying and really working hard, as she said, after today's, she will again start exploring for the new, what will be the next class. So that's a wonderful thing, really. And this shows the real teacher concept. Teacher always wants to give and give. So this is the right time. My teacher used to say, take whatever is possible at this time, because once you go out and then you meet the colleagues, there you are in a parallelly running and the professional. You become a profession, but not the teacher and student relationship. So you people are lucky to have these wonderful programs which are being organized free and with great caution, great exploration. Please be there. And in last program, I do remember, and I quoted this also into the committee report that in the Oxy first chair, the students participated not from South India only, from everything, even from Uttar Pradesh there were, Madhya Pradesh there were, Gujarat, so all the corners, and everybody appreciated. I congratulate you, Dr. Vijaya and Dr. Geeta Lakshmi and your team for this wonderful initiative. And I'm lucky, and it's my good luck that I'm like to be with you as a teacher is always teacher. So maybe in Foxy, may not be in Foxy, but teacher always wants to be in these programs. So thank you very much. And I will wish you all the success for this program. And let's go ahead with the scientific.
Yes, ma'am. Thank you.
Thank you.
Thank you so much.
Thank you.
Thank you. Thank you very much, Kiran ma'am. It was really wonderful
Thank you.
to be over. And we'll keep up the spirit of Oxy and Foxy by continuing this academic sessions. Thank you, ma'am.
Right.
We'll move on to the teaching session. We have one of the best teachers, Dr. Rama. Dr. Vijaya ma'am, you can introduce her, ma'am.
Dr. Rama is head of the department and of Gynec Oncology Regional Cancer Center, Trivandrum, and she has been trained in advanced laparoscopy from National University Hospital, Singapore, and Royal Marsden's NHS, UK. She trained in colposcopy in Cape Town, South Africa, and the International Federation for Cervical Pathology and Colposcopy approved trainer in colposcopy in India. And she has 20 years of professional experience in gynec oncology, and her area interest is, oh my God, clinical and molecular research. That is the toughest part in gynec cancer. She has 74 publications in the peer-reviewed journal, authored several chapters, and she has 384 citations to her credit. Oh, such a wonderful CV, Rama ma'am. We are just wowed by your CV, and we are very happy to have you as a presenter and discussion on ovarian cancer. Welcome, Rama ma'am. Over to you.
Thank you very much, and thank you organizers, Dr. Vijaya, Dr. Geeta Lakshmi, Dr. Kiran madam, and thank you for this opportunity. Let me start my screen sharing. One sec. Can you see my screen? Is it?
Yes, ma'am.
Full screen, you can make it full screen, ma'am.
Yeah, it's full
Right,
screen.
sure.
Thank you. Thank you. Okay. So why are we talking about ovarian cancer today? As Dr. Kiran madam has rightly pointed out, it is a silent killer. Because ovarian cancer, as you are seeing in your practice, majority of them are asymptomatic. They come in advanced stages. And in spite of whatever we do, it has the highest case fatality ratio. But we must remember that the ovarian cancer is not a single cancer. As you can see from this picture, from anatomy, we know that ovary has got a surface epithelium, it has got germ cells, it's got stroma. So ovarian cancer can be from the surface epithelium, which is the most common, the epithelial ovarian cancer. Under this, we have all the 5 histologies, serous, which includes the high-grade serous and the low-grade serous, the mucinous, the endometrioid, clear cell, and other varieties. From the germ cells, you have the germ cell cancers, the most common being dysgerminoma. You have the yolk sac, embryonal choriocarcinoma, and teratoma, which can be benign or malignant. We'll go to each of this. From the stroma, you have the stromal cells. So from there, you get all variety of tumors, but the malignant or so-called malignant ones are the granulosa cell tumor and the Sertoli Leydig cell tumor. So we must remember that the most common is epithelial ovarian cancer, and they form around 80% of ovarian cancers. Germ cell cancers form around 10 to 15%. Others are sex code stromal is only 5 to 10%. And you also get metastatic cancers in the ovary from other sites like colorectal, even breast, etc. So today I'll be discussing under the following headings. First, the management of adnexal mass. As you know that it's one of the most common things you see in your clinical practice. Then the role of laparoscopy or minimally invasive surgery in management of adnexal mass, area of great controversy. In every conference we fight over this. And surgery for ovarian cancer, surgical staging for early ovarian cancer and cytoreductive surgeries. The newer treatment modalities, HIPEC and targeted treatments, germ cell and borderline tumors, they're very good tumors and although rare. And if time permits, what we can do to do some risk reduction for ovarian cancer. So the first topic, evaluation of adnexal mass. What are adnexal mass? As you know, adnexia includes the ovary, fallopian tube and other connective tissue, and they are asymptomatic. They are usually detected incidentally in your clinical findings. In your pervaginal examination, you may get an adnexal mass or in your ultrasound. And the main evaluation goal in an adnexal mass is to rule out a malignancy. So what all can come as adnexal mass? It can be gynecological or non-gynecological. Under non-gynecological, you have benign or malignant. We know the most common in a reproductive age group is a functional cyst, corpus luteal cyst. You may also get some leiomyomas, which are subserous, may present as adnexal mass. And all these things, tubo-ovarian abscess, teratomas, all are benign. Malignant ones, as we have described before, includes all the ovarian cancers. But we must remember that from the location, even non-gynecological conditions like benign situations like appendicular abscess, diverticular abscess, pelvic kidney, bladder diverticulum may come as adnexal mass. And other cancers like GI cancers, retroperitoneal sarcomas, metastatic cancers. So when you're discussing a differential diagnosis postgraduates, you have to remember all this depending on the patient's symptoms. We have to discuss these as the differential diagnosis of adnexal mass. So the most common, as I've said before, in the reproductive age group, we get follicular or corpus luteal cyst, endometriosis, PCOS, abscess, and borderline tumors. In the postmenopausal, as you know, the risk of cancer is higher. So if of all the adnexal mass, around 13% in the premenopausal and 45% in the postmenopausal can be cancers. So how do you evaluate these adnexal mass? As I said before, majority are asymptomatic and you detect it incidentally. But they may have symptoms. When you get pain in an adnexal mass, you have to think about three situations. One is torsion, second is rupture, third is bleeding or even infection. So pain in an adnexal mass presents as an emergency. So rule out torsion, rupture, hemorrhage or infection. And when you have infection, along with the pain, you also have fever or vomiting because it becomes a tubo-ovarian abscess. When you have dysmenorrhea, dyspareunia associated with an adnexal mass, you think about an endometrioma. Ovarian cancer, we know, are silent, and so the patient presents with blotting, abdominal distension, vague pain, which is not a specific colicky pain, early satiety. What is early satiety? Early satiety means after taking a small amount of food, she feels full. That is, it is not loss of appetite. After she used to eat whatever she used to eat, she is not able to now. So that is early satiety. These are the features of ovarian cancer. And you also get bleeding symptoms, AUB, postmenopausal bleeding, in estrogen-producing ovarian tumors, which are the sex cord stromal tumors. So these are the usual symptoms. And so in your history, you start with the age of the patient. We know that higher the age, in postmenopausal, the risk of malignancy is higher. You should also ask about the personal or family history of malignancy, which includes breast, ovarian, or colorectal cancers, because there is a hereditary breast ovarian cancer and also the Lynch syndrome. We'll come to that. We know that around 20% of ovarian cancers are hereditary, associated with BRCA mutation. BRCA1 carries around 40% and BRCA2 around 27% risk of ovarian cancer. And again, Lynch syndrome, 5 to 10%. Also, in your history, you should ask about these risk factors. These are risk factors like nulliparity, early menopause, early menarche and late menopause, primary infertility, endometriosis. Primary infertility as such is not associated with ovarian cancers, but it is usually due to endometriosis, because we know that long-standing endometriosis carries a risk of development of endometrioid adenocarcinoma and clear cell carcinoma. If you get an MCQ like which is the most common cancer in endometriosis, it is not endometrioid adenocarcinoma, it is clear cell carcinoma. So endometriosis is associated with clear cell ovarian cancer and endometrioid adenocarcinoma. So in your history, you should also ask about history of endometriosis and infertility. And in your clinical examination, it should start from the performance status, the BMI, vitals, general physical examination, but emphasize on the presence or absence. You have to say that there are no palpable supraclavicular, axillary, or groin lymph nodes. All these can be metastatic sites of ovarian cancer, so this should be mentioned. And your chest examination, you know that advanced ovarian cancer is associated with pleural effusion. So we have to mention in your clinical examination that all lung fields are clear, there is no pleural effusion, or if it is so, you have to mention that. Abdominal examination, apart from the mass, you have to look for free fluid, because advanced ovarian cancer is associated with ascites. And if you're feeling a mass, describe the mass, because ovarian cancer is usually a hard, fixed nodular mass with restricted mobility. They're usually bilateral. They're usually associated with ascites. And in your local examination, you visualize the cervix, vagina, look for any deposits in the vagina or cervix, which is usually unusual in ovarian cancer. You palpate the mass by manually, and also do a per-rectal examination. In the per-rectal examination, you have to assess whether the tumor is infiltrating the rectum. If it is infiltrating, what is the extent of infiltration? Is it reaching up to the mucosa or not? And also you have to look for deposits in the pouch of Douglas. This is one place where we always say that when you want to palpate a peritoneum, it is possible only in your pouch of Douglas. So peritoneal deposits in ovarian cancer are palpable in the pouch of Douglas. So you have to mention the presence or absence of pouch of Douglas deposits. So once you're done your clinical examination and you found a suspicious adnexal mass, the next is imaging. So all the available imaging modalities starting from ultrasound, MRI, CT and PET-CT are there. But we must remember that ultrasound remains the first imaging technique for evaluation of adnexal mass, and it definitely helps us to triage women into risk management strategies. Transvaginal ultrasound has got around 90% sensitivity and 97% specificity. So in your transvaginal ultrasound, you should assess the size of the mass, whether it is cystic or solid, because we know that solid masses with thick septae, with mural nodules, with papillary excrescences, bilateral masses are more associated with malignancy, and also look for free fluid in the pelvis. So the features that suggest malignancy are irregular and thick septae, papillary projection, solid areas, and moderate echogenicity. And it should always be combined with an ultrasound abdomen, where you look into the extent of the mass beyond the pelvis. You look for the nodal disease, because ovarian cancer can spread to the lymph nodes. You look for ascites, peritoneal deposits, involvement of liver and other abdominal organs. And ultrasound can be combined with color Doppler, because we know that malignant masses are have increased vascularity, and hence your color Doppler may help you to assess the vascular characteristics. Neovascularization, abnormal blood vessels, and low resistance flow can be made out in your color Doppler evaluation. You can also use your 3D ultrasound, a 3D power Doppler, which is a newer technology which will show a central flow and blood flow within septae or excrescences and complex vascular architecture. But now studies have not shown a definite advantage of 3D over our usual Doppler in diagnosing ovarian malignancy. We know that ultrasound is a subjective thing. So various study groups have developed various imaging criteria to predict or models to predict the malignancy in an adnexal mass. The most popular among them is the IOTA, which is predicted the diagnostic accuracy in a very simple way. IOTA, stands for the International Ovarian Tumor Analysis Group. The IOTA study is the largest study in the literature for the sonographic diagnosis of ovarian tumor. started in 1999, and they describe certain simple descriptors, so simple iota, simple rules. So this has got the best sensitivity and specificity to classify the adnexal mass. So iota ultrasound rules classified the rules as M rules and B rules, and M rules are for malignancy. So if you have one or more M rules without B rules, it's a malignant mass. One or more B rules without M rule is a benign mass. If both M and B rules are there, the mass is inconclusive and needs further imaging, which can be MRI or an expert ultrasound. So these are the B rules. B rules are unilocular cyst, presence of solid component, if at all is there, it's less than 7 millimeter, acoustic shadowing, and the size of this is less than 10 centimeter, no color, no blood flow on color Doppler. So these are the B rules. M rules, irregular, there are 5 M rules, irregular solid tumor, presence of ascites, at least 4 papillary structures, irregular multiloculated solid tumor larger than 10 centimeter, and prominent blood flow color Doppler. So these are the M rules. So with this M rule and B rule, around 75% of the adnexal masses can be classified as benign or malignant. As we said before, or some 25% may be inconclusive and needs further imaging. So which is the further imaging? Remember that CT, MRI, PET CT are not recommended as the initial evaluation of adnexal mass. It should always be ultrasound, and only for this suspicious lesion you should go for further imaging, which is usually MRI, which is used to characterize the adnexal mass. Because compared to transvaginal ultrasound, MRI has got a better ability to characterize the lesion, and it's got a detection rate of around 92%. But again, cost and availability can be an issue. And MRI scoring has been developed for adnexal lesion, which is called the adnex MRI, which helps to standardize the imaging evaluation, just like your BRADS for breast. We have the adnex MR scoring. And this is the adnex MR scoring: benign, probably benign, indeterminate, and probably malignant. So when do you do a CT scan? It is not routinely done for the adnexal mass evaluation, but when you find an ovarian malignancy, to assess the operability, you go for a CT scan, and that is to detect ascites, omental peritoneal deposits, involvement of adjacent structures like the bowel or the bladder, presence of lymph nodes, liver metastasis. All this can be assessed by CT scan. So it's basically when you have a diagnosis of ovarian cancer, you go for a CT scan. PET CT, as I mentioned before, is very rarely done. It is not done in the initial evaluation of an adnexal mass, because you must remember that PET CT has got so much false negative and false positivity. Your teratomas, endometriomas, all that may show some FTG uptake, and now it's very difficult, put you in a very difficult situation. So basically, we don't do PET CT for the initial evaluation of adnexal mass. We don't do it for an initial ovarian cancer workup also. The role of PET CT is limited to our patients with recurrence. When you're planning, again, you don't do it for all your recurrences. When you have a single site recurrence and you're planning surgery for that, you do a PET CT to rule out recurrence elsewhere. So PET CT has got very limited role in ovarian cancer evaluation and management. So after imaging, you also do the tumor markers. So these are the common tumor markers: CA125, CEA, CA99, AFP, LDH, and beta HCG for the germ cell tumors. CA125, you must remember that it's a marker with very low specificity, because in addition to ovaries, all the coelomic epithelia secrete CA125. So pleura, pericardium, peritoneum, whenever there is an inflammation or irritation of all these structures, CA125 is elevated. And also other epithelia like kidney, lungs, stomach. So cancers in these situations also produce a CA125 elevation. So CA125 is a very non-specific tumor markers. But CA125 is elevated in 80% of epithelial ovarian cancers, but only 50% of stage 1 cancers have elevated CA125. So your elevated CA125 or non-elevated normal CA125 doesn't rule out a malignancy. And it is elevated only in 65% of mucinous cancers. What I want to tell you is it's most commonly associated with serous cancers, and around 65 and around 75 to 80% of other histologies like endometrial, clear cell, and undifferentiated have elevated CA125. Physiological situations also show elevated CO125, pregnancy, menstrual cycles, benign conditions like endometriosis, fibroids, salpingitis, PID, non-gynecological benign situations, cirrhosis liver, as I said before, the peritoneal irritation, hepatitis, pancreatitis, cancers of breast, colorectal, pancreas, lung, endometrium, cervix, all have elevated CO125. So CO125 more than 35 is the normal cutoff we take. And so more than 1% of normal adults and 20% with benign tumors have elevated CO125. So basically, CO125 has got a very low sensitivity and specificity to rule out malignancy in an adnexal mass. So what do? This is, we go into the guidelines. They say that a premenopausal woman with more than 200 unit CO125 and postmenopausal with more than 35 may be referred to an oncology center, but if it's associated with other features in imaging, you have to intervene. These are the germ cell markers. We'll go into detail later. So HE4 has been proposed as a better identifier of ovarian cancer than CO125. The cutoff is 70 for premenopausal and 140 for postmenopausal, because HE4 elevation is not affected by endometriosis and other benign conditions. So it is thought to as a more reliable marker of epithelial ovarian cancer. CEA is expressed with the mucosal cells, so it is associated with elevated in all the GI malignancies, stomach, colorectal, all the GI malignancies have elevated CEA, and also the mucinous cancers of ovary also show a elevated CEA. The upper limit is usually 3.8. The relevance of CEA is that you have to rule out it is to rule out a metastatic cancer in the ovary. We must remember that when you get a mucinous cancer in the ovary, most common is a metastatic cancer from a GA primary. Mucinous tumors are common in the ovary, but when you have a mucinous cancer, it is usually metastatic. So you use a combination of CEA and CA125. You go for the CA125 to CEA ratio, and if it is more than 25, you have a suspicion of a bowel cancer, and you go for an endoscopy to rule out a bowel primary. So an adnexal mass evaluation, to summarize, you have ultrasound, you have the tumor markers, you have the B-rows, you feel it is benign, you keep the patient on follow-up, and if it's persisting or enlarging, you go for surgical intervention. And a postmenopausal woman, you have a higher threshold of diagnosing malignancy and you intervene earlier. Now, my next topic is the minimally invasive surgery in ovarian masses or adnexal masses. Let me present to you my patient, a 57-year-old patient who was diagnosed in ultrasound with the suspicious adnexal mass, 7 centimeter mass with thick septae and increased vascularity with a fibroid uterus. The CA125 level was only 21 unit. So what is your choice of surgery now? Can I go for a laparoscopic surgery? Why am I concerned about doing laparoscopy? Because if my tumor finally turns out to be malignant and I rupture the tumor, it upstages my ovarian cancer from stage 1A to stage 1C. We'll come to the staging later, but once you rupture, it becomes 1C, and that will necessitate chemotherapy. And rupture, disseminates the disease and affects the patient's survival. So, and you know that with larger tumors, laparoscopy leads to a higher chance of rupture. So before you consider laparoscopy to my patient, I should consider the personal and family history of malignancy, my examination, my imaging, and tumor marker. And this is a guideline proposed by the STU-ACOG for a newly diagnosed pelvic mass, and they say that in a postmenopausal woman with CO125 more than 35, premenopausal with 200, with the presence of ascites, abdominal or distant metastasis, family history, they should consider as a suspicious for malignancy, and your spill during laparoscopy should be avoided. So this sort of picture, you have a large unilocular cyst with B-rolls positive, you can consider laparoscopy. So you can safely go ahead with laparoscopy. But when you have a picture like this, which shows a malignancy, you have to be cautious. So because danger of MIS in malignant masses, in addition to rupture and spillage and upstaging and necessitating chemotherapy, you get the risk of port site metastasis, scar recurrences, accelerating the malignant spread and delay in definitive treatment of cancer. So during laparoscopy, you should avoid rupturing or spilling the cyst, and if at all you're proceeding with laparoscopy, take the cyst in toto without spilling into the laparoscopic bag. Partial excisional cyst, mosylation of mass is always contraindicated, because you know what happens when you mosylate or spill, the tumor just spills into the peritoneal cavity. You know that ovarian cancer spreads by transcoelomic or transperitoneal spread along with the peritoneal fluid. So during laparoscopy, your carbon dioxide helps to spread the cancer, make sure that the cancer cells reach all the nooks and corners of the peritoneal cavity. This carbon dioxide enables there and favors implantation there, because carbon dioxide favors a acidic, makes a acidic environment, which also favors a tumor implantation. So it sort of disseminates the tumor. And you also get the port site recurrence rate ranging from 1 to 13%. Why does port site recurrence happens? Because it happens due to trauma to the site, frequent removal of tumor, and your specimen retrieval through the port. If you're not putting the specimen in a bag and you're just taking out through the port, the specimen will be contaminating the port, and also the ascites will leak through the port. So port site recurrence is very common. So large masses removed by aspiration, mosylation, piecemeal debulking through small incision, all upstage disseminates the disease. And do we have an evidence to say all this? We know that there are no RCTs, or ethically it is not possible to have a randomized study. But this particular study by Vergot et al., he can see that this is all early epithelial ovarian cancer. And this is the survival of patient who had no rupture. And this is a survival curve of the patient who had rupture during surgery or before surgery. So there is a definite survival disadvantage of patient who has got an intraoperative rupture. It was an independent risk factor for poor survival. And the latest Vigostat classification have introduced a new stage for surgical spill. It becomes a 1C1 disease. And this is one picture. We operated a patient who had an ovarian tumor, which was removed through a transverse scar, and she came to us later with a scar recurrence. So the guidelines for laparoscopy in adnexal mass, all adnexal masses with suspicious ultrasound findings should be considered potentially malignant. So you can proceed with laparoscopy, but always take the consent for laparotomy and surgical staging, because during your laparoscopy, if you're finding a malignant mass, like we saw in that picture before, you should proceed with the proper surgical staging for ovarian cancer in the same sitting. And when you introduce the trochas, it should be perpendicular to the abdominal wall. If at all it is spilled at the trochar site, you should be excising the port site. Spillage should be avoided. Avoid puncture. Minimize your tumor manipulation. All specimens should be extracted in an endobag, protecting the abdominal wall. And so remember that laparoscopy should not be performed when the tumor is larger than the endobag. If you have a 30 centimeter large tumor, you have to spill it. And if this tumor is looking malignant in your imaging and tumor marker, better proceed with laparotomy. And if at all you spill the tumor, you're not supposed to, but then go for a peritoneal lavage. Ideally, you need a frozen section. You should proceed with the surgical staging in the same sitting. And if at all you have done a laparoscopy and the patient needs a restaging, it should be considered as an oncological emergency, and resurgery with proper staging should be done as early as possible. And remember, staging laparotomy is the gold standard for treating ovarian cancer and should not be considered as a failure of laparoscopic surgery. Okay, so now we'll go to ovarian cancer surgical staging. Why surgical staging? Because staged diagnosis is the most important prognostic factor. Ovarian cancer just disseminates from here, from the ovary, it goes to the peritoneum, it goes to the lymph nodes, it goes to the liver. So your accurate surgical staging is important to optimize the patient's survival. FIGO staging was started in 1973. The recent revision is 2014. And it is based on the fact that epithelial ovarian cancer, especially the high-grade epithelial ovarian cancer, which is the most common, arises from, not from the ovary, from the distal, it arises from the distal end of the fallopian tube, from the fimbrial end. And the precursor for epithelial ovarian cancer is serous tubal intraepithelial carcinoma, called the STIC. It is a precursor of high-grade serous cancer, primary fallopian and primary peritoneal cancer. So it arises from the fimbrial end. And low-grade serous cancer, we know that epithelial cancers include high-grade serous, low-grade serous, mucinous, clear cell, and endometriotic tumors. Mucinous and low-grade serous arises from borderline tumors. They got the, it's like benign, borderline, and malignant. Clear cell and endometrioid, as we discussed before, comes from endometriosis. So the most common cancer is from the fallopian tube end. And this is the latest staging. So tumor stage 1 is confined to the ovary. Stage 2B, stage 1A is confined to ovary with capsule intact. No tumor on the surface or negative washings. 1B is both ovaries. What do you mean by capsule intact, no tumor on surface? How do you diagnose ovarian surface involvement? You call it surface involvement when you're seeing tumor cells exposed to the peritoneum, exposed papillary structures, exposed neoplastic epithelium. See, this tumor has got exposed tumor surface. The capsule is ruptured here. Once you open the abdomen, we saw this. We document it as a tumor of size 10 into 15 centimeter with surface deposits. This is important to document because your final stage and final treatment decisions based on your intraoperative notes. So very important to have a proper documentation of the disease at presentation. So this is surface involvement. Stage 1C has been subclassified as we discussed before. C1 is surgical spill during your surgery. C2, this particular picture that you've seen before is C2 because surgical spill happened before surgery. And C3 is presence of ascites, malignant cells and ascites or washings. And we know that survival is better for C1. It is lesser for C2 and even less for C3. So again, as we discussed before, laparoscopy, there is a 25% chance of spill compared to open, where there's an 8% chance for spill. So our policy during surgery should be to avoid spill during surgery. Stage 2, you know that it is spread to the pelvis, to the uterus, the fallopian tube, or other pelvic structures. Stage 3, this is whatever I have put in red is a newer modification in 2014 staging, where they reclassified stage 3 A1 as A11 and A12. Nodal metastasis come under stage 3 A1. So if you have an ovarian tumor with nodal metastasis, it is stage 3 A1. Depending on the size of nodal metastasis, it can be A11 or A12. Stage 3 A2 is microscopic extrapelvic disease. B is macroscopic, less than 2 centimeter. 3C is peritoneal metastasis, more than 2 centimeter. So this is the typical presentation. We know that this is the liver, the subdiaphragmatic area with all deposits. So this is the stage 3C ovarian cancer. 4 has been reclassified as 4A and B. 4A is pleural effusion. But when you're seeing pleural effusion, you have to take a cytology and make sure that it is cytology positive before you call it a stage 4A disease. 4B is all other metastasis, including our inguinal lymph nodes. Anything outside abdomen is stage 4B. So how do you do surgical staging for ovarian cancer? You go by an incision, which is midline vertical incision. The first step is to take a peritoneal fluid cytology. If ascites is there, you take the ascitic fluid cytology. Otherwise, you put 30 ml of normal saline and wash the peritoneal cavity. And before, then you explore the peritoneal cavity. Look biopsies from all suspicious areas. In addition to routine peritoneal biopsies from subdiaphragmatic, bilateral paracolic, bilateral pelvic, pouch of Douglas, and bladder peritoneum. Then you remove the tumor first and send it for frozen study. If the frozen shows malignant, you proceed with hysterectomy, BSO, your peritoneal staging. As we described before, in addition to omentectomy, includes peritoneal biopsy. The omentectomy for early ovarian cancer is infracolic omentectomy. And you also need to do pelvic and para-aortic node dissection for all early epithelial ovarian cancers. Appendicectomy only for mucinous cancers. Why are we doing lymphadenectomy for cancer ovary? It's an essential part of staging because you can see that 8% of pelvic and 15% of para-aortic nodes will have metastasis in early ovarian cancer. So a systematic pelvic and para-aortic node dissection is needed. What is systematic node dissection? You define the boundaries of pelvic node dissection. You can see the genitofemoral nerve here, which is the lateral boundary. The obstetra nerve is the dorsal boundary. The internal iliac artery here is the medial boundary. So you remove all the fibrofatty tissue within these boundaries and you call it a systematic pelvic node dissection. And for a para-aortic node dissection, the upper boundary is a renal vein crossing the aorta. The inferior border is the common iliac, ureter, and the ureter forms the medial border. And so this is the para-aortic node boundaries. You remove the precaval, the pre-aortic, the para-aortic lymph nodes. So you are stripping the vessels of the nodal tissue. So in early ovarian cancer, we do a complete peritoneal node dissection because why are we doing all this without any apparent without any disease seen in your vision? That's because in early ovarian cancer, there is a 20% chance of positive peritoneal washing, 7% chance of diaphragmatic peritoneal biopsies becoming positive, 10% chance of other peritoneal biopsies, omentectomy 30%, and retroperitoneal nodes around 25%. So after your proper surgical staging, you will be upstaging around 30% of patients. Now, what happens in advanced ovarian cancer? Advanced ovarian cancer, has spread beyond ovary to the peritoneal cavity. Tumor deposits are seen in the peritoneum, subdiaphragmatic, everywhere. So it is treated with a combination of surgery and chemotherapy. All stages beyond stage 1 is advanced. So in advanced ovarian cancer, we call it a cytoreductive surgery. Stage 1, which is early ovarian cancer, it is a surgical staging. Anything more than stage 1 is cytoreductive surgery. And if it is not primarily operable, that is, if you are not able to get complete cytoreduction, you go for a neoadjuvant chemotherapy and go for an interval cytoreduction. So cytoreductions can be primary, interval, or secondary. Secondary is for recurrences. When you're operating in the primary setting for advanced ovarian cancer, you call it a primary cytoreduction. If you're operating after neoadjuvant chemotherapy, you call it a interval cytoreduction. The benefits of cytoreduction, why should you go for a cytoreductive surgery? Why can't you go for chemotherapy? Because the benefit of cytoreduction is removing a tumor helps in making it more chemosensitive and definitely better survival to the patient, because the large poorly vascularized tumor becomes pharmacological sanctuaries. The chemo will not reach there. The larger the tumor bulk, lesser will be the growth fraction. So the chemo works better with a small residual tumor. And again, the host immunity is improved. The patient starts eating and her immunity also improves. So what is your aim of surgery in cytoreduction? It is to get optimal cytoreduction. Optimal cytoreduction has been variously defined. It started with 2 centimeter, then 1 centimeter. And now the definition of optimal cytoreduction as per the 2010 GCIG consensus is no residual disease. So as you can see that as we change the definition of optimal cytoreduction from more than 1 to less than 1, the patient survival is also improving. From 30 to 35 months, it is now 40 to 44. And with this, no residual disease, the patient is living beyond 2 years, 70 months and beyond, just with surgery. So if primary cytoreduction is that good, why are we not primarily operating? Because primary cytoreduction needs optimal cytoreduction. That is, you're not supposed to leave behind any tumor after your primary cytoreduction. So if you feel that your surgery is not going to attain optimal cytoreduction, the better option for the patient is neoadjuvant chemotherapy and interval cytoreduction. And again, it's a big extensive surgery lasting for 6 to 8 hours. The patient has got a higher complication rate, higher morbidity, multiple bowel resection. So a primary cytoreduction should always obtain optimal cytoreduction, because if you're leaving behind residue, you're increasing the morbidity without survival benefit. So how do you decide whether you should go for primary surgery or chemotherapy, neoadjuvant chemotherapy? You decide based on the patient's age, her performance status, her ability to withstand your surgery. You also look into the tumor markers, they're not very reliable. You look into the CT picture and also a laparoscopic assessment. We'll come to that. So tumor markers, again, more than 500, but that's not a very reliable marker. You can go for the CT findings, how extensive the tumor is, and you can assess your surgery. You can also do a diagnostic laparoscopy as your initial assessment and go for a faculty scoring. I'll come to that. So CCT, you look for features of inoperability, which includes large peritoneal deposits, multiple lung mets, suprarenal para-aortic nodes, porta hepatis deficits. And you have various predictive models like Bristow's model and Nelson's model, which can be used to predict this optimal cytoreduction in a patient. But better than CT, laparoscopic assessment fares better, because when you plan your cytoreduction, you start with a diagnostic laparoscopy. You do a laparoscopic assessment of the disease, and if you're feeling that it is going to result in suboptimal cytoreduction, you abandon the procedure and go for neoadjuvant chemotherapy. And you also take a tissue biopsy at the setting. So this is the Fagerty scoring proposed by Anna Fagerty, where we have all these criteria: peritoneal disease, diaphragmatic, mesenteric, omental, bowel. Please refer this: stomach and liver metastasis. Scored a 0 and 2, and a score more than 8 predicts suboptimal cytoreduction. So you do a staging laparoscopy or a diagnostic laparoscopy to prevent an unnecessary laparotomy. Again, this is a small procedure, so it doesn't affect survival. So all primary cytoreductions should be preceded by a staging laparoscopy. And when you are not able to get primary, when you are not able to attain primary cytoreduction, the patient goes to the next best option, which is interval cytoreduction after neoadjuvant chemotherapy. So neoadjuvant chemotherapy is given when the patient is not fit for surgery, like she is very thin, emaciated, she cannot go for a primary surgery. And also when you don't have the expertise, when your diagnostic laparoscopy shows optimal cytoreduction is not feasible. So what are the advantages of neoadjuvant chemotherapy? Your chance of getting optimal cytoreduction is better. The surgery becomes easier, less extensive, and we have some evidence which says that neoadjuvant chemotherapy does not compromise survival. And we know that tumor biology is a very important prognostic factor. So you get an idea of tumor biology after neoadjuvant chemotherapy. But there are certain problems like neoadjuvant chemotherapy induces fibrosis and makes complete cytoreduction difficult. We are not sure whether we are compromising on the patient's survival, because earlier the tumor is removed, better is going to be the patient's. There is a possibility that neoadjuvant chemotherapy may result in chemoresistance, and various studies have shown that the more the number of chemocycles, lesser is going to be the survival. So neoadjuvant chemotherapy should only be used when the patient is not fit for a patient or the disease is not amenable for a primary surgery. You have various evidences for neoadjuvant chemotherapy. Please go through this. So after surgery, the patient goes for an adjuvant chemotherapy. The standard is carboplatin and paclitaxel given intravenously every 3 weeks and total of 6 courses. They're usually well tolerated. Now, what are the newer things in the field? The new one is the HIPEC or intraperitoneal chemotherapy. What is intraperitoneal chemotherapy? We know that the tumor spreads into the peritoneal cavity, and your chemo should have a higher concentration where the tumor is.
Madam?
Hello, Sakiti.
You're mute, ma'am. Sahiti?
Sakiti.
Yes, ma'am.
Sorry, can you hear me now?
Yeah.
The slide is gone, ma'am. Slide is gone.
Slide is gone.
Screen share, yeah.
Can you see me?
Yeah,
Can you see me now?
Yes, ma'am.
Yes.
Okay. So how does intraperitoneal chemotherapy work? We know that ovarian cancer is in the peritoneal cavity, and we need the chemo to be in the peritoneal cavity to have the maximum tumor kill. So the cytotoxic effect of the chemotherapy is higher when you give it directly to the peritoneal cavity. And you can also reduce the toxicity by reducing the systematic exposure of chemotherapy. Yeah. So what is HIPEC? HIPEC is in hypothermic intraperitoneal chemotherapy. So hypothermia or temperature increasing will increase the drug uptake into the malignant cell. It alters the cellular metabolism and working in synergy with the cytotoxic drug. It increases drug penetration, inhibits the repair mechanism, DNA repair mechanisms, and makes the chemotherapy more effective. So that is how hypothermic intraperitoneal chemotherapy works. So it is preceded by a cytoreductive surgery where you remove the entire tumor, and then it is followed by chemotherapy, which is given at a temperature used is 41 to 42 degree. The cytotoxic drug acts by inducing apoptosis and activating the heat shock protein, increase sensitivity by impairing DNA repair. It inhibits angiogenesis, and it's got a direct cytotoxic effect. And again, it reaches the entire peritoneal cavity and all the areas of peritoneum. But it is a very it should be managed carefully, because when you put hypothermic intraperitoneal chemotherapy, the circulatory state goes to a hyperdynamic circulation, the cardiac output increases, the heart rate increases, and your anesthetist has to be very good expert to manage the patient to prevent hypothermia. They have to cool the patient, and we go for a closed abdominal technique. The intra-abdominal pressure also increases, so the venous return decreases. Again, hemodynamic instability and renal damage are all complications. The drugs used, we usually use cisplatin for ovarian cancers, mitomycin for bowel cancers. When you have a mucinous cancer, we go for a mitomycin. Otherwise, it's usually cisplatin. It is given in carrier solution, which is 1.5 dextrose peritoneal dialysis fluid. Oleum used is 1.5 to 2 ml, 2 liter per minute, and flow rate of around 1 liter. The temperature is 42 degrees usually. So you select a patient with good performance status, and only after a complete cytoreduction with optimal cytoreduction, we go for a HIPEC. PCI or peritoneal carcinomatous index is not an exclusion factor. Even when the peritoneal disease is widespread, we can go for a complete cytoreduction. But when the cytoreduction is suboptimal, HIPEC is not ideal. Again, when you are doing when you're giving HIPEC, you should take particular attention to get a proper hemostasis, and bowel anastomosis, if at all you have done, should be meticulously done. The peritoneal cavity is washed many times with hydrogen peroxide solution, multiple times with saline to remove the cellular debris. And all adhesive lysis should be done, and then we go for HIPEC. So HIPEC is delivered using a pump. It is a commercially available machine. We have a HIPEC machine which also maintains the temperature. It's got thermometers which in the inflow and outflow tracks. 2 inflow and 2 outflow tracks are put into the abdomen, and we usually goes for the closed technique. What is your evidence for HIPEC? This is the most quoted Vandriel trial, which showed that surgery plus HIPEC in the interval setting had a better survival advantage. As you can see, the survival was better in surgery plus HIPEC arm. And so HIPEC is now the standard of care for, wherever available for interval cytoreduction. Now, the next is targeted therapy. We know that in this era of genetic testing and mutation profiling, we are looking into going ahead of the standard chemotherapy. We are looking for targeted treatment into the ovarian cancer. I'm not covering the entire thing, but only the commonly available and useful things. The potential targets, we have the angiogenic inhibitors and PARP inhibitors are the most commonly available thing. Folate receptor inhibitors, the immune checkpoint things are all coming up, but whatever used now are the anti-VEGF and PARP inhibitors. So let's just go through that. Angiogenesis inhibitor, this blocks the growth of blood vessels. We know that cancer cells have got increased vasculature, the blood vascularity is more and blood vessels grow there. So this angiogenesis inhibitor, by blocking the growth of blood vessel in a tumor, starves the cancer of its nutrition, its oxygen, and the tumor dies. So that is the basic concept in simple words. So what do we have? We have commercially available bevacizumab, available as Avastin. It is an angiogenesis inhibitor. It's used in many other cancers. It's also used in ovarian cancer. It's given IV 2 to 3 weeks. The side effects are there, but it is actually very less. So it's given as maintenance treatment in ovarian cancer and also for recurrences. So bevacizumab is a commonly used drug for ovarian cancer as maintenance treatment. This is the evidence for bevacizumab. We have the GOG 218 and ICON 7 trials, which showed a definite improvement in progression-free survival with bevacizumab. And what are PARP inhibitors? Again, new drug, you may get PGs, you may get recent advances question on PARP inhibitors. What is PARP? PARP stands for polyadenosine ribosphosphate. So PARP inhibitors work by, that DNA repair happens by single strand breaks and double strand breaks. So PARP inhibitors are involved in the single strand DNA breaks. So when these PARP is involved, PARP enzyme is involved in the repair the single strand breaks. So when you have a PARP inhibitor, the single strand breaks accumulate, then double strand breaks also happen, and so the cell death happens. So they also exploit the BRCA mutated patients by a concept called synthetic lethality, because we know that BRCA mutated patients have double strand DNA repair mechanism issues. So PARP inhibitors act in synergicity to BRCA mutated patients. But studies have shown that clinical benefit of PARP inhibitor is not just to BRCA mutated, but to all population. Entire population of high-grade serous ovarian cancer shows the benefit of PARP inhibitor. But it's more for BRCA mutated patients. So this is how the PARP works. So BRCA mutated, along with that PARP inhibitor comes, you have this synthetic lethality and cell death happens. The commercially available drug is olaparib. It is an oral drug. The side effects are less. The most common side effects are fatigue, nausea, vomiting. Other serious side effects are lesser, but there is a rare toxicity like leukemia, AML can happen in this patient in around 6 to 8%. So these are the various studies and PARP inhibitors. It started from various targeted drugs. It started with bevacizumab, then olaparib came to the market, and you have the evidence on combined olaparib plus bevacizumab now. Niraparib is also commercially available. For patients who are not without doing BRCA mutation, you can give niraparib also. So so many targeted drugs are coming up. And these are the evidences. Solo 1 is for olaparib, Polo is for olaparib and bevacizumab. Prima trial was for niraparib, and you have other drugs also. So various targeted drugs, targeted treatment is now coming up in maintenance treatment of ovarian cancer after your primary surgery. Now, let's just go into the less common tumors, the germ cell tumors. Germ cell tumors, as I said before, arise from the germinal epithelium. They are rare tumors. They affect the reproductive age group female, and they affect the younger age groups, adolescents and the young adults. 95% of germ cell tumors are benign. The metrocystic teratoma, otherwise called the dermoid cyst, is the most common germ cell tumor. Malignant germ cell tumor forms only less than 5%, and they include dysgerminoma, which is the commonest, then yolk sac tumors and immature teratomas. So germ cell cancers, when you have, affect younger age group. So definitely you should go for a fertility preserving surgery. They are good tumors. They have got good prognosis. Majority presence in stage 1 disease. And even in advanced stages, the results are usually good because they are chemosensitive tumors. So this is how a dysgerminoma looks. We call it a brain-like tumor. Dysgerminomas are most frequent tumors and most frequent in girls with gonadal dysgenesis. 10% of dysgerminomas can be bilateral, and they have the IHC of PLAP and c-KIT positive. They present with large lobulated tumors. The tumor marker LDH, which is a non-specific marker, and also the PLAP, placental alkaline phosphatase, can be a tumor marker. Survival, the results are good with dysgerminoma, 86% overall survival, and early stages more than 90% survival. Metrocystic teratoma, or your dermoid tumor, is the most common tumor. It has got all the 3 epithelial, endodermal, mesodermal, and ectodermal cell layers. So you get skin, cartilage, glia, glandular elements, and bone. Classically, there will be a nodule in the wall. But metrocystic teratoma, although a benign tumor, may harbor malignancy, which is usually a squamous cell carcinoma from the epithelial elements. This is how a normal dermoid cyst happens, but rarely squamous cell carcinoma can arise in a dermoid cyst. Immature teratoma, unlike your metrocystic teratoma, are the malignant counterparts. They are soft and fleshy. So they look like this. They are soft, fleshy. I've taken this picture from textbooks only. So they contain immature neuroepithelial tissue, and they're categorized as grade 1, 2, or 3 based on the immaturity of the elements. So we diagnose this by a pelvic ultrasound, and these patients usually come with pain because germ cell tumors happen in young girls, and they're rapidly growing tumors. So because of capsular stretching, they come with abdominal pain, or sometimes they present with large masses. Your pelvic ultrasound will diagnose this. You can confirm with an MRI also. But remember, when you get a pre-menarchal girl with a germ cell tumor, suspected germ cell tumor, which is usually a dysgerminoma, you have to do a karyotyping because dysgenetic gonads are at risk of dysgerminoma. So in a pre-menarchal girl with a germ cell tumor, go for a karyotyping. Why? Because both gonads are at risk of developing dysgerminoma, and You have to remove both the ovaries. Otherwise, it is always fertility preserving surgery for germ cell tumors. So the tumor markers, the various tumor markers, alpha fetoproteins, beta HCG, and LDH for dysgerminoma. And alpha fetoprotein is specifically for endodermal sinus tumor, although embryonal cancers and mixed germ cell tumors also show AFP. Choriocarcinoma usually for beta HCG is elevated, but in 5% of dysgerminomas, again, beta HCG is elevated. Immature teratomas don't have tumor markers. Mixed germ cell tumors have all these elements. When you're operating a patient with germ cell tumor, it is always fertility preserving. One, because they are all young females, and second, because they come in early stages and they are very chemosensitive. So fertility preservation is the norm, and the minimum surgery is a unilateral salpingo-oophorectomy. Only when you have done a karyotyping and diagnosed dysgenetic gonads, which I said before, you should be doing a karyotyping in a premenarchal girl. Dysgenetic gonads are diagnosed, you should go for a bilateral oophorectomy because both ovaries are at risk of developing dysgerminoma, but you leave the uterus there. Your fertility preservation, but it is not cystectomy. It's always unilateral salpingo-oophorectomy. Very rarely, when you get dysgerminomas in elderly age groups, you go for a complete surgery with hysterectomy BSO. Stage 1A dysgerminoma and 1A grade 1 immature teratoma need surgery only. Rest of the tumors are treated with chemotherapy, which is bleomycin, etoposide, and cisplatin, and it's a very chemo-sensitive tumors. And recurrence rate is low, but recurrences can be salvaged usually with chemotherapy. Now, borderline tumors, borderline means it's coming in between benign and malignant. Again, it affects younger patients in their 20s and 30s. Again, you go for a conservative surgery, you keep the uterus and a part of the at least one ovary. You need to do surgical staging. There is no role of chemotherapy for borderline tumor. These are also tumors with good prognosis. So you go for a surgical staging as an invasive cancer, but you don't do lymph node dissection unless the nodes are enlarged, and you almost always go for fertility preserving surgery for borderline tumors. So the same steps, peritoneal cytology, hysterectomy BS if the patient has completed family, otherwise you retain the uterus and one ovary. You avoid lymphadenectomy, but you go for multiple peritoneal biopsies. Appendicectomy for mucinous tumors, we don't do nowadays, although it's there in all textbooks. It's done only if the appendix is abnormal. And you do a fertility preserving surgery, retaining the uterus and at least a part of one ovary. So if you have a unilateral tumor, you go for a US, so unilateral salpingo-oophorectomy. When you have a bilateral tumor and you remove one tumor and you go for a unilateral salpingo-oophorectomy, send it for frozen. Frozen shows it as a borderline tumor. Go for a cystectomy in the opposite side. Retain the normal part of ovary. You know that after cystectomy, the recurrence rates are higher, but the patient gets time to complete a family. Recurrences, again, you can operate and survival is good. There is no role of chemotherapy for borderline tumors. Now, after covering all the ovarian cancers and telling that it's a very bad cancer, can we do anything to reduce the risk of ovarian cancer? This has been the statistics compiled by IARC and the Global Ovarian Cancer Chapter, and they showed that the incidence of ovarian cancer, even in our practice, we are seeing more of ovarian cancer. Now, we don't know why. Is it because the patients are living longer? The longevity is now more. So, but we are seeing more ovarian cancer in the practice. And so, if you don't do anything to do this, to control this, we are going to lose around 4 million women by 2040 if we don't do anything about it. That's a predicted statistics by the International Agency for Cancer Research. So can we do something about it? We know that ovarian cancer is asymptomatic. We can't screen it. Your tumor marker C125 is not good enough, and your imaging is not sensitive enough. So what can we do to reduce the mortality of ovarian cancer? The only way possible is to identify a group of patients who are at higher risk of developing ovarian cancer, go for an early diagnosis and risk management for these patients so that we can reduce the cancer incidence and mortality. So we know that hereditary cancer constitutes around 24% of ovarian cancers. And so this 24% patients are eligible for ovarian cancer prevention. And these are the genes associated with ovarian cancer. We are already described the BRCA1 and 2, the Lynch syndrome with all these 4 genes, MSH2, MLH1, MSH6, and PMS2. And other rare cancers are also associated with hereditary ovarian cancers. So this BRCA1 constitutes around 52% of hereditary cancer, BRCA2, 28%, and all the other genes. So BRCA mutated, BRCA genes are tumor suppressor genes, BRCA1 in chromosome 17 and 2 in chromosome 13. They lead to DNA instability, telomerase shortening, and they lead to a higher risk of breast and ovarian cancers. So this is the risk. This is a normal patient. This is a BRCA1 mutated and this is a BRCA2 mutated. They are at higher risk of developing breast cancer and ovarian cancer. So we can see that they have around 40% risk of developing ovarian cancer in a BRCA1 mutated and 11% in a BRCA2 mutated patient. So if this is a risk in a general population, 1 out of 100 will get ovarian cancer. In a BRCA mutated, 30 out of 100 will get ovarian cancer. So that is a lifetime risk in a BRCA mutated BRCA1 and BRCA2 patients. So what can we do about this? Do we have any Indian data? This is the study done from TMH Mumbai, where they included 9 Indian centers and they looked for BRCA mutation, and they found that around 15% of their patients had BRCA1 mutated and around 6% had BRCA2 mutated. So we have our Indian data which showed that around 15 to 20% had BRCA mutation. So which patient so to whom should we offer the BRCA testing? And as per all the available guidelines, NCCN, SGO, ASCO, all women with epithelial ovarian cancer should undergo BRCA testing, because even the TMH study showed that family history was not a relevant factor for diagnosing BRCA mutation. Even those who had only 50% of patients with BRCA mutation had a positive family history. So it should be done for all, BRCA study should be done for all women with epithelial ovarian cancer. Why should you do this? The benefit is to the patient, because BRCA carriers have got better treatment modalities like PARP inhibitors, a better response. They have better response to chemotherapy also. But more important, you can identify BRCA carriers among their relatives and apply risk reduction strategies. So we should not wait for the persons to get cancer, but we should identify people who are likely to develop cancer and prevent cancer. This was written by Cheryl Rose. She wrote a book about this, saying that BRCA testing saved her life and her sister's life. And you must all have heard about Angelina Jolie, who did a BRCA testing and went for a risk reduction mastectomy as well as a salpingo-oophorectomy. Angelina came somewhere, this is Angelina's mother, and she came somewhere here. And so she got a BRCA testing, and this was made a BRCA testing and risk reduction strategies very popular. Do we have guidelines of BRCA testing and management in India? This is the Indian guidelines proposed by the Indian Society of Medical and Pediatric Oncology, where the patient undergoes genetic counseling. Definitely BRCA testing or any genetic testing is different from all your testings, because the patient needs a pre-test counseling as well as a post-test counseling. In your pre-test counseling, you ask about the medical history, the family history, and you discuss her about the need for genetic testing, as well as the implications of genetic testing, the social, the financial, and all the other issues, the benefits as well as the harms. Then also the insurance issues, they may come out of their insurance because of this. And after the result, again, she needs a definite post-test counseling. You have to address her anxiety, and discuss with her all the risk management strategies available for her. Her reproductive plans also you have to consider. So the genetic testing should be preceded by pre-test and should be followed by a post-test counseling. The testing for BRCA is done in 2 ways. You can do it in your tumor cells when you don't have to go for the pre-test and post-test counseling, and that's called somatic testing. In the patient, when you're doing in the blood or saliva, it's called the germline testing. You can actually do both somatic as well as germline testing. The patient, as we discussed above, you can screen the patient for other BRCA-related cancer like breast cancer. But the most important is to identify her family member. We call it cascade testing. This is a cascade. So BRCA testing means you identify the risk cascade testing just means that you identify the family member for that particular gene, which you identified in a patient, you do for the family member and identify them so that you can provide them with all the reducing strategies. You have the surgical strategies, the medical prevention with tamoxifen for breast cancer prevention, aspirin for colorectal prevention, the anastrozole, then screening, you can go for the breast cancer screening, lifestyle changes, prenatal genital testing. So what are the surgical options? The most popular is reducing salpingo-oophorectomy, is reducing mastectomy, and you can do a salpingectomy and delayed oophorectomy, chemoprevention with OCP and tamoxifen, and surveillance for the breast with MRI mammogram, ultrasound CA-125 for ovarian cancer. The efficacy is not proven. The typical risk-reducing strategy for ovarian cancer for BRCA mutation is risk-reducing salpingo-oophorectomy done laparoscopically, typically between 35 to 40 years after childbearing. In BRCA2, the average age of cancer is sort of 8 to 10 years later, so you go for it only by 40 to 45 years. But around 4% are at risk of developing primary peritoneal cancers. You have to tell the patient that her risk of developing primary peritoneal cancer is less than 5%. Excuse me. And when you're done a risk-reducing salpingo-oophorectomy, the data shows that around 2.5 to 17% have occult ovarian fallopian tube or primary peritoneal cancers in their pathology review. So by doing a BRCA testing, you can reduce ovarian cancer by 96%. By doing a risk-reducing salpingo-oophorectomy, you can reduce your ovarian cancer risk by 96%, breast cancer by 53%. But then genetic testing has got its issues like anxiety. You tell the patient her risk of developing cancer. She's got her anxiety, fear, depression. All these issues have to be addressed in your pre-test and post-test counseling. And again, the chance of getting married off for young girls, again, we have to consider all that. And remember, testing should not be done in less than 18 years. Only after 18 years, you can do, only after they become adult, after 18 only, you are supposed to do a genetic testing. But you have to remember that it's unlike your other tests. There are so much, it's associated with various psychological issues also. And when you're done an RRSO for a very young woman, you can also go for a short-term HRT, which doesn't increase the breast cancer risk. So with the Angelina effect, they have shown that after Angelina Jolie did this reducing salpingo-oophorectomy, in US at least, the number of patients coming forward for genetic testing and risk-reducing surgery has gone up. Probably something like that should be done in our patients also. So coming to the end of my talk, to summarize, we know that ovarian cancer is a risk in all adnexal masses and it should be properly evaluated by your ultrasound, and tumor marker will also contribute. You should be very careful about minimally invasive surgery when you have a suspicion of ovarian cancer. Minimally invasive surgery can be done if the tumor can be removed without spill, and all surgical staging needed for ovarian cancer is done along laparoscopically. If that is not possible, open surgery with surgical staging gives good cure rate in early ovarian cancer. Advanced ovarian cancer, surgical cytoreduction with optimal cytoreduction, which is no residual tumor after your cytoreduction, gives maximum patient survival. You have all the new modalities now with HIPEC and so many upcoming targeted treatment. The less common tumors, the borderline and germ cell tumors, definitely affecting younger women, deserve fertility preserving surgery. And genetic testing and risk-reducing salpingo-oophorectomy should be offered to BRCA patients. Doing a genetic test for all your epithelial ovarian cancers and identifying BRCA mutation, doing a cascade testing for their family members, and offering risk-reducing surgery and screening is also possible. Thank you very much. All these guidelines you can refer ICMR. Thank you.
Thank you, Dr. Rama, for a wonderful starting from the basics to the advanced, and starting from the evaluation of the adnexal masses, and you went on for clinical features and differential diagnosis, and going into the steps of primary cytoreductive surgery and interval cytoreduction, and also the role of PARP inhibitors and the HIPEC and molecular gene therapy and also the target therapies and whatnot. It is a complete what to say given in a nutshell for the PGs. It's really a wonderful. I'm very happy that I chose you for this ovarian cancer. You've definitely have done your 100% involvement in this teaching. One I can start with one question. Is there a role of radiotherapy in ovarian cancer?
No, there is practically no role for radiotherapy in ovarian cancer. In clear cell ovarian cancer, there has been some studies for limited disease in the pelvis, which is not operable. But again, no, radiation therapy is practically not used in ovarian cancer treatment.
What about synchronous cancer, Rama?
Synchronous cancer means two primaries in the ovary and endometrium, and the new FIGO staging for endometrium has included this stage 1A3. So that means that you have an early ovarian cancer and early endometrial cancer. So ovarian cancer should be unilateral, should be confined to one ovary. There should not be any spread beyond the ovary. The endometrial cancer again should be confined to the endometrium or less than 50% myometrial infiltration. And basically early endometrial, early ovarian cancers come under synchronous cancer. So it is now grouped as stage 1A3 by FIGO in endometrial cancer staging.
Okay, Rama.
Same histology, no, madam, because the endometrium is also showing.
Yeah, it is same histology, and the important thing is they should be differentiated from metastatic. Metastatic from the ovary to endometrium. So endometrium to ovary means it is advanced and they need adjuvant treatment. If you're diagnosed it as synchronous, basically it's a pathologist who should be diagnosing. Surgical step is actually same. Once a pathologist says it's synchronous, the patient doesn't need any chemotherapy. Or for endometrium, if it is metastatic to ovary, means it is stage 3 and you have to go for adjuvant treatment. That is not needed. If you diagnose it as synchronous, it's early in both sides, only surgery is enough.
So sometimes it's really confusing to say whether it is a metastasis from the endometrium or it is a synchronous, no? Sometimes.
The differentiating thing is you'll have disease elsewhere. The endometrial cancer will be deeply infiltrating myometrium. There will be disease in other locations like lymph nodes will have metastasis. So something like that is there, take it as metastatic. So if it fulfills the criteria of early in ovary and early in endometrium, it is synchronous.
Can it be in both the ovaries, ma'am?
No, it's usually one ovary only.
Okay.
It's one ovary only.
But in such case, after the laparotomy, for the endometrial part, they can have radiotherapy, no, ma'am?
They don't need to. If it is early endometrium, means it's less than 50% confined to the endometrium. Then they don't need it. It comes under 1A3, so no adjuvant treatment.
Okay. But if there is other factors like LVSI or if it's a cervical stoma,
then it's unlikely to be synchronous. It's likely to be metastatic.
Oh, it's metastatic. Okay.
Both should be in early stage. That's what madam says.
Both should be in early stage.
Yeah. Understood.
Okay.
I think if there is no questions in the PG, I think I was waiting for the chat box to maybe ma'am has covered everything. But I also remember why there is early satiety in the symptomatic, no? That was the first symptom of dyspepsia and bloating sensation. Why is that? Usually we ask in the exam, no, Rama?
We usually ask why the patients get early satiety. It's because the patients have a large omental cake or ascites or a large ovarian tumor itself, which prevents the stomach from expanding. So the stomach can't accommodate more food. A little food she eats, she feels she is full. So that is early satiety. It's not loss of appetite. She has her appetite, but she can't eat much. So we call that early satiety. It's just a typical symptom of ovarian cancer.
Okay.
What about this clockwise inspection, Rama? Is it gone or it is still there?
It is there. That is because the peritoneal fluid spreads in a clockwise manner. So you start from the cecum, go in a clockwise manner just to make sure that you have gone everywhere. It's a meticulous inspection of the whole peritoneal cavity. You have to see. So it should be a liberal vertical incision. You have to see the entire peritoneal cavity. And other than routine peritoneal biopsies, take biopsy from all the abdominal areas. So if your ovarian tumor is stuck to a peritoneum in the abdominal wall or lateral peritoneum, take a biopsy from that place, because only if that biopsy is positive, your stage is increased. By your description that ovarian tumor is adherent to the anterior abdominal wall doesn't make it a stage 3A2 or stage 3B. Only if that biopsy you have taken from that place shows an ovarian cancer deposit, then only the stage is going to rise. So more important is to take biopsy from wherever suspicious area, all the areas where the tumor was adherent should be biopsied.
And what about this supraclavicular nodes, that Witchow's node? Is it still there?
Yes, supraclavicular node makes it a stage 4B disease, and the patient goes for neoadjuvant chemotherapy.
Dr.
Rama,
Dhanalakshmi is there.
am I
Yeah.
audible?
Right.
Hello.
Dr. Sandhu.
Good evening, Dhanalakshmi ma'am.
Lakshmi, what about the peritoneal index?
Yeah, PCI or peritoneal index is used to assess your whether you would be able to cytoreduce or not. But in ovarian cancer, we found that in spite of the index, cytoreduction is possible. And even for HIPEC, PCI is not a contraindication. But even when PCI is high, you can proceed. But we always document our PCI.
Well, are we supposed to do as part of your regular staging? We don't do it because for fear of causing injuries, we don't do it.
No, PCI is just documenting whatever the size of the tumor and the extent of peritoneal spread. So PCI is just documentation of your extent of peritoneal spread. It is always good to document PCI in your ovarian cancer cytoreductive surgeries because when you audit later, you can assess with your morbidity and other things. It's good to document PCI, but just because PCI is higher, you don't abandon your surgery. The most common reason of abandoning cytoreductive surgery is due to extensive bowel involvement, which is surface deposits, small bowel serosal deposits, extensive means you can't compromise that much length of the small bowel. It lead to short bowel syndrome if you're removing more than 1.5 meter of small bowel. So that is the usual reason of inoperability during your cytoreductive surgery, extensive involvement of small bowel. So for that, a diagnostic laparoscopy is useful. You can do a diagnostic laparoscopy, assess the extent of disease, plan your surgery, and then go for cytoreductive surgery. Rather than opening and finding out it's inoperable, the patient will have time to heal her wound. This is just DLAP, so she can be sent home next day and she can start a chemotherapy.
Or an appropriate imaging won't help in assessing this
Imaging with CT scan will help. If your CT scan is showing extensive disease and you're not, you feel that cytoreduction is not feasible, like liver metastasis, large deposits in the porta, and extra abdominal disease, excluding pleural effusion. Pleural effusion is not a contraindication. You have lung parenchymal, pleural deposits, all that. You go for a neoadjuvant chemotherapy. If your CT shows operable, then only you plan a cytoreductive surgery. But CT has got its limitations, so you can do a laparoscopy, assess the operability, then go for a cytoreduction.
What is the role of PET-CT?
PET-CT, I discussed practically no role, and for adnexal masses, don't use it because the patient will panic and you will be in a soup. Because even endometriomas, corpus luteum, everything will show a PET uptake, and you know that normal endometrium also shows a PET uptake. Then it's difficult to reassure the patient. Once you've done an imaging, you're supposed to answer the patient's question, and you have to make sure that there is no tumor there. So PET-CT is practically not used in the initial evaluation of adnexal mass. Early ovarian cancer, again, not used. We use it, or as per the real indication comes in recurrences. When you're planning a secondary cytoreduction, I didn't go into recurrences because it's again an exhaustive thing. So when you have a recurrent tumor, a single site recurrence, you're planning surgery, like she has recurred in the vault, it is infiltrating rectum, you're planning anterior resection. We want to make sure she doesn't have lung mets or liver mets, so you can go for a PET-CT at that point. Otherwise, no, because large majority of ovarian tumors like clear cell, mucinous, they don't have PET uptake. So PET-CT is practically not used in ovarian cancer now.
What about the parietic node? If it is enlarged, you don't do the laparotomy, close and come back and do a chemo and then do it at a later stage. That was one group of thought. Is it still holds good, Rama?
No. Whatever debulk, when you're able to remove the parietic node enlarged is not a contraindication because routinely we remove the enlarged parietic node. When it is not, when you cannot remove it, depends on whatever is above the renal vein, we don't go there because celiac trunk, small bowel vasculature will be affected. So when parietic nodes are enlarged, we routinely go for a parietic nodal debulking. Actually, when you compare two group of patients, one is having this extensive nodal disease, another group is with peritoneal disease. These nodal ones fare better. That's why in the last revision, FIGO has restaged the nodal disease. Previously, it was all 3C. Now, FIGO was restaged as 3A1 because they are all better compared to abdominal peritoneal disease. So, nodal disease actually fares better. And whenever possible, the nodal disease should be removed. So para-aortic node enlargement is not a contraindication. Definitely, they should go for a cytoreduction. Unless it is sort of encasing vessels, then it's retrocrural nodes. There are certain situations when it can't be removed, like mediastinal. It is spread beyond the para-aortic to mediastinal or supraclavicular. Then you go for neoadjuvant, then go and address the node. So nodal disease in ovary, para-aortic is actually the first draining site. We know that ovarian artery comes from the aorta and ovarian vein drains to the IVC and the left renal. So para-aortic is actually the first draining node. So majority of ovarian cancers have para-aortic. They should be removed.
Yeah. The thing is, I was really surprised when you said MRI scores better over CT. We were under the impression for endometrial cancer, it is MRI, any soft tissue. For ovarian, for the lymph nodes, it is CT, like that. The teaching goes like that.
Yeah, the teaching is, as if you are right, because ovarian cancer, if you look, it is always CT. We don't do an MRI in an ovarian cancer to assess operability. The role of MRI is just to characterize the adnexal mass. You have an adnexal mass in ultrasound, you don't know if it is benign or malignant, you can go for an MRI and characterize the mass, so that if you want to do laparoscopy and do it, you want to rule out a malignancy, it is MRI. But the standard treatment, as you said, the standard protocol, as you said, is it is CT for ovarian cancers, MRI for endometrial cancers. This is an adnexal mass characterization. That is the only situation you go for an MRI to characterize that mass. Otherwise, it is always CT.
CT.
Assess operability, it is CT.
You haven't told about the platinum sensitive and resistant. Please, you just.
Yeah, I never went into the
bombarding you with questions, but this is exam question, Rama.
Yeah, platinum sensitive means the patient has got disease recurrence within 6 months of a platinum treatment, platinum-based treatment. So now it's actually questionable because platinum resistant means, platinum sensitive means within 6 months she did not have, her disease-free interval is more than 6 months. Less than 6 months means it's platinum resistant. Tumor is growing during a platinum-based treatment, you call it a platinum refractory. So these are the three terminologies: platinum sensitive, resistant, and refractory.
And nice to talk to a person who is from the same place where I did my PG. I did from Trivandrum Medical College.
Okay, what year? When was it?
I was PG in 89 to 92. Anyway, I'll talk to you later. It's an open forum. I have a patient who is 22 years, recently married, and she had a right ovarian mass. She opted, after counseling, she opted for an open surgery. She did not want frozen because frozen may not give the appropriate result. She wanted an open surgery and take the tumor as such. And the tumor, even though she did not want frozen, we wanted to know the immediate diagnosis. We did a salping oophorectomy and sent her for histopath. It came as 6-cord stromal tumor. She's only married for 6 months. And so we are waiting for the final histopath report.
Yeah, 6-cord stromal tumor, whatever surgery you've done is enough. You are not spilled or ruptured the tumor, that's very good. So that is enough. You can do fertility preservation for her. So I thought I put a slide for fertility preservation, somehow I forgot. So fertility preservation should be done for all germ cell, borderline, 6-cord stromal, and for early ovarian cancers. Basically, when the patient desires fertility, you should attempt fertility preservation even in early epithelial ovarian cancer. So other than epithelial, germ cell, borderline, 6-cord, it's always remove the tumor, leave the uterus, take biopsies from the peritoneum and omentum. That's all. Then in early epithelial ovarian cancer, it's slightly controversial, but if the patient desires so, you can plan your treatment in 2 sittings because your frozen, as you said, may not always give your results. Frozen may show borderline, final histopathology may show malignant. It's usually like that. When you get a malignancy in frozen, it is always malignant. When you get a borderline or benign, there may be other areas which were malignant. So you can't totally base your surgery based on frozen. You always on frozen. If you get malignant, you go for a complete staging with no dissection, peritoneal biopsies. But if patient desires so and it's early, confined to ovary, you keep the uterus and the opposite ovary.
Of course, she said she'll wait for the final report. She did not want us to take biopsy from anywhere. She said, let it be a open biopsy. I'm willing to go for one more surgery next week also. So let the final report comes. So she wanted us to remove only.
What about chemotherapy during pregnancy, Rama? BEP is
Chemotherapy can be given after first trimester. You can give chemotherapy, but before the planned delivery, you stop it by before 3 weeks of delivery. By 34 weeks, you sort of stop chemotherapy. During that second trimester and early third trimester, you can give chemotherapy.
So is cisplatin better or carboplatin better during pregnancy?
The usual regimen is given. Carboplatin and paclitaxel is the usual chemotherapy, and that there is no dose or drug compromise. The usual chemotherapy is given.
even that bleomycin can be given, no? In germ cell, if it is a dysgerminoma or something.
Bleomycin can be given patients less than 40 years. More than pregnancy, it is not safe in patients more than 40. So bleomycin can be given in pregnancy.
Yes, Rama. Thank you so much, and for this
Thank you.
wonderful. We would love to hear on and on about ovarian cancer and almost all cancers for that matter. Both the three cancers are really changing every day, especially endometrial cancer has changed so much. Initially, I thought I would ask you to talk on endometrial. Then I thought these ovarian students are very much every time the exam questions endometrial ovarian cancer is more. So I thought I'll ask you the ovarian cancer. Maybe if the time permits in the later dates, I might ask you again for or we can invite you for a Oxy conference to give a talk on. Thank you so much for coming and spending your valuable time on behalf of Oxy and all our EC members. Sincere thanks, Raman.
Thank you so much for the
Kiran
opportunity.
ma'am, are you there? Kiran ma'am?
Kiran ma'am.
I'm there.
Yeah, yes,
it was
ma'am.
wonderful. Yeah,
Yes.
I was there and I was listening all the interactions. It was very wonderful. I told you I was traveling, so I did. I mean, this was the very. I mean, I enjoyed the whole my journey. I learned, and I mean, it was like again being a PG student sort of thing. PG class attending from A to Z, and Dr. Rama has beautifully explained various things, which is very. I would say have a great mastery over these problems. So very nice. I don't think I have any particular question. Although with every patient, unique situations do keep coming, as just now was being discussed. That I let the person. I'm sorry, I don't know the name. Like doctor, you were discussing that that you have taken up open given a biopsy, and the result is Vitic germ cell tumor. I mean, so these are the unique situations we keep on facing in practice every day, and then you have to decide what treatment you have to give and what you can give, what you cannot give. So very extensive, very nice, very clear, and still crisp. This has been the very informative session. Thank you very much, Dr. Rama, and I'm sure the PGs.
Thank you.
And also, yeah, we all have been benefited. And as Dr. Vijay was saying, the endometrial cancer, which used to be the most simple one at when we were PGs, we used to think, it's so easy. But now it is so much has changed. Like molecular diagnosis and the classification has completely changed the management of endometrial carcinoma. So, of course, it's a winning science. Very nice. Thank you, Dr. Vijaya, for organizing this wonderful Oxy session. And I'm sure we'll keep on doing like this.
Yes, ma'am. Next month with a much more interesting topic. Yes, ma'am.
Thank you, madam.
Thank you. Thank you, Rama. Thank you so much.
Thank you.
One question in the chat box. What about meds management, ma'am? It's already, I think, mentioned in the presentation. Just one can give an answer, ma'am.
Yeah, meds management means the ovarian cancer is spread beyond the ovary. You go for a cytoreductive surgery whenever possible. When you have an extra abdominal disease, so when the patient is not suitable for cytoreductive surgery, you go for a neoadjuvant chemotherapy and reduce the disease and then go for a debulking.
Yes. Thank you very much, madam. You touched every aspect of ovarian cancer. I was telling all my postgraduates, I was sending them messages and telling them, you will learn in and out of ovarian cancer, and no stone will be left unturned. And so please make use of this class and attend. So I asked all our PGs to join.
Maya has joined. Maya Menon?
Maya ma'am? Maya ma'am is there. Yeah.
Okay, if she wants to ask anything. Okay.
So with we are very grateful to the entire team, Oxy members, office bearers, Foxy office bearers, Kiran madam, who's a chairperson of Medical Education Committee, and our team, Vijay ma'am, Geeta Lakshmi ma'am, from wholeheartedly, we thank you very much for actually preparing this and teaching at a level where all of us can understand, not only the PGs as clinicians, we also have our own doubts whenever these kind of tricky situations come, how to go about this. So it was very lucid presentation. Thank you very much, Rama madam and the entire team. And I also thank our treasurer, Dr. Mala is very busy with her daughter's wedding. So I will give the vote of thanks on her behalf. So I thank everyone, the office bearers of Foxy, Oxy, and also Kiran madam and Rama madam for this wonderful presentation. And I also thank Sheel for giving a platform every month. They've never said no. Programs.
I will just request Dr. Vijay or everyone, please give me a report of this, how many have attended,
Yes,
and the details and the important photographs.
The pictures, yes,
So,
ma'am. Yes.
yeah,
Yes,
so like previous one, you were there, so we can make a report of it and give it to
Sure.
the medical community. Foxy.
Yeah.
Sure.
Okay. Bye-bye. Yeah. Bye all.
Thank you.
Thank you. Sheel
Good
for
night.
more. Good night, ma'am.
Good night.
Thank you, ma'am.
Sakiti, thank you so much. Rama, thank you so much. Please keep in touch. Dana, thanks for joining and interacting.
Sure.
Everyone, thank you so
Thank
much.
you.
Good night.
So thank you.
Good night.
We'll see you all in the next class.